you
Now,
hear me?
yes, perfect.
Okay.
Okay, so welcome to the California Right Care Initiative Virtual University of Best Practices. I'm Hattie Reese Hanley, co-founder and director of this 12-year collaborative to spread best practices. We are quite blessed today to have 171 people signed up to be with us. And we have wonderful leadership with us, including our co-chairs for our Bay Area group, cardiologist, UCSF, Dr. Evelyn Stock, and Dr. Nurali Vora, neurologist from Stanford. In addition, we have leadership from across the state, leadership from our Right Care Initiative, who've been with us for many years, including Stanford, University of California, San Francisco, of course, our mothership, UC Berkeley School of Public Health, Palo Alto Medical Foundation, the Be There staff from our original, very first collaborative that we started, one of four now, metro areas in California. In addition, we have the Air Force with us and Blue Shield of California leadership, as well as HealthNet. In addition to our leadership, I want to thank our biopharmaceutical supporters, and they include Amarin, Amgen, Boehringer Ingelheim, Genentech, Johnson & Johnson, and Novo Nordisk, as well as Blue Shield, California Department of Public Health, and the Santa Clara Health Trust. Thank you all not only for supporting the race against the pandemic, but for supporting the Right Care Collaborative. Without your support, this work would not be possible. I want to also do a shout out to Scott Flynn, one of our original co-chairs, who, along with one of our leaders from Southern California, Keith Emmons, have pressed our group to learn how to use remote technology so that we can all come together. And I am just so grateful that we have people as far away as the Centers for Disease Control Million Hearts program and the Navajo Nation. So I want to just call out the wonderful health systems and public health that are with us. We have the California Department of Public Health leadership, San Mateo and Santa Clara Public Health, as well as the community clinics, as well as Cedars-Sinai, California Health and Wellness, the Chronic Care Coalition, Community Health Partnership of Santa Clara and San Mateo County, Dignity Health, Greater Newport Physicians, Healthcare Partners, the American Heart Association, Jade Healthcare, Kaiser, LA Care, Memorial Care, Mercy Medical Group, SCAN, Sutter, Scripps, and Santa Clara Independent Practice Association, as well as White Memorial. So as we dive into the substance of this very important program today, I want to thank the experts and leaders from across the medical and scientific communities who have come together in this time of great peril to learn from one another. Our co-founder, the chief healthcare lawyer for the state of California for many years, established our motto, which is, in all right care gatherings, we compete against disease and not each other. And now, as I pass the baton to our co-chair, who's going to lead the first half of the day as our facilitator, Dr. Evelyn Stock, could you please go to the next slide? I want to point out that we are a data-driven program, and that on the CDC website, we could see early on that this pandemic was starting to emerge. So if you look at the influenza-like illness data, you can see the early emergence of a very unusual pattern in the red W pattern you see from this year as opposed to all other years. Next slide, please. So I'm going to pass the baton to our dear cardiology co-chair, Dr. Evelyn Stock, who comes to us from the University of California, San Francisco, to talk about the very important comorbidities that we are challenged with. And with that, Evelyn, thank you so much for facilitating the first half of the meeting.
Thank you, Hattie, and thank you all for being here with us. I cannot start this session today without profoundly acknowledging my condolences to everyone who has been touched in one way or another by this pandemic. And it has been now a good 6 weeks since the lockdown started in earnest, but while in the Bay Area, we've acted heroically. There have, signs of stress are unmistakable. I tell my husband each morning that we're one day closer to the end of this thing, but that slim comfort, and we know that we might be headed for months or even years of this down the line. On the clinical front, we have good news in the Bay Area and California. We have weathered quite well this first wave of the storm. 6 weeks ago, we had about the same number of COVID-related deaths as New York. And as you all know, San Francisco has, up to my best knowledge, 22 deaths to date from COVID-19, while New York City, more than 15,000. And several other regions had been nearly as hard hit. Our hearts go out to all of them. And, as I want to acknowledge the generosity and courage of everybody, and how physicians and everybody affiliated to hospitals have managed current resources. I want to introduce our next speaker, Dr. Master in Public Health, Rhonda McClinton-Brown. She's the Director of Health Communities Branch at the Santa Clara County Public Health Department. Ms. McClinton-Brown has more than 25 years of experience in the field of community health and is currently the Director of the Health Communities Branch of the Santa Clara County Public Health Department. In her role, Rhonda organizes, coordinates, and evaluates the county's health communities programs and maintains the data to assess the health of the population. Because of her unique position, Rhonda works closely with the county on chronic disease injury and prevention, nutrition and obesity prevention, traffic safety, and tobacco prevention. And we will hear today from her. Thank you, Rhonda, for joining us to give us a perspective of COVID-19 and context in the Santa Clara Valley.
Hi, I just want to give you a caveat that I am really not the expert to be doing this. So if there's someone from public health who's actually in the communications group or in the emergency operations center, they're much more qualified to do this than I am. But since I've been attending these meetings, I agreed to just share what's on the public available website. I have no more information than what is available for the public. My role in public health right now is the continuation of operations side. So I am not involved in the COVID response at all, really. So I just want to make sure that I give that disclaimer and provide the caveat related to my role in this response. And so what I agreed to do is to just share with you what's on the Public Health Department website, which is the dashboards. The hospital dashboard, which I wanted to also share, was not available today, so I don't have that, but you can see the numbers here. And so as of yesterday, there was about 2,100 cases, about 23 new cases a day. In the past week, we have averaged about 23, 24 cases a day, which shows that the number of cases is dropping. So if you look at the red on the bottom, that's the daily count of the cases. And you can see it's kind of dropping with some blips in there. And the blue graph at the top shows the steep of the curve, which you can see is beginning to flatten because of our sheltering in place. So what we're doing is starting to work. Currently, there is a new data team, and they are now reporting data on cases by race in addition to death by race, with the caveat that the case data is not as accurate and complete as the race data. So it is not mandated currently that all labs report by race. So all of the people that have been tested positive don't necessarily have all the data related to them. But what the county is doing now is posting what they have. And so you can see overall, most of the cases are adults, really young adults through midlife adults. And then if you go to the next slide, and I'm going to have you go back in just a minute, but just in this slide, you can see the deaths are mostly older adults, 70 and older. But like the slide that you just showed, most of the deaths are related. There's at least one or more comorbidity associated with those deaths. Also, when you look at the death by race and ethnicity, you see some disparities. And so African Americans represent 7% of the death, but only 2% of the population. Asian Americans represent 30 something percent, about 33% of the deaths and 23% of the population, and Latinos represent about 32% of the deaths and about 25% of the population. So there's some disparities with Latino populations. I'm sorry, Asian American is more on par. It's like 30 something percent. So the disparities are with African American and Latino populations. The percentages of deaths is much more significant than their percentage by race. Oh, I thought I heard somebody say something. One of the things that I've been tracking personally, for my own peace of mind, are we doing the right thing, is looking at the current hospitalization rate. And so if you've been following the dashboard, which is posted and updated daily, if you look back weeks ago, the daily census of hospitals was in the 200s each day. Each hospital reports how many COVID patients they have. And in the last week, that has dropped down to below 200. It's been hovering in the last couple of days between 170 something and 168 to 175-ish kind of. So the number of people that are in the hospital is decreasing. You can go to the next slide. And then this just shows the number that's on the County and Public Health Department website that tells you what the current case rate is by city. And you can see there's a very large percentage of the cases are in the city of San Jose, which, naturally is one of the most populous cities in the county, but you can see what that looks like in this area. And I think there's I missed, yeah. And then you can go to the next slide. And this slide is the laboratory dashboard. So it shows to date, as of yesterday, there was 25,575 tests that were reported. And then 2,105 were tested positive. And so the other number that I've been looking at for the last month is the test positivity rate. And it used to be about 13%, but as time goes by, it's been slowly dropping. Now it's about 8%. So I just wanted to, I think that's the last slide I had. Is that correct?
Yes, it is. And thank you so much, Rhonda McLean-Brown, for presenting this data from the Santa Clara County. I wanted to just remind everyone on our panel and our participants on the line that you can expect to hear a chime throughout the meeting, and that chime is just to help us keep track on our agenda. And so thank you so much again, and we'll return it back to Dr. Stock to help facilitate.
Great, thank you.
Thank you, Rhonda, for that very very updated and interesting view on the Santa Clara. Are there any questions from the audience?
You may submit your questions using the Q&A box found at the bottom of your screen. Additionally, you can use the chat box to submit any comments during the presentation as well. We have one question/comment from Dr. Steve Sidney of Kaiser. It is hard to interpret whether there are disparities in the deaths by race/ethnicity without knowing the race/ethnicity composition of the underlying population.
Sorry, I was muted. Yes, it is. It is. So all we have is, and I think on the chart you can see the population as a whole in the cases, but you don't see it necessarily on the dashboard. By the race of the population as well. Yeah, that's the best guess that we have right now.
We have another comment and question from Dr. Steve Shortell from UC Berkeley. Are you training any contact tracers?
Are we training contract? Oh, I see them now. They're on the chat. So the Emergency Operations Center. Well, let me back up. If you listen to the press release on Facebook Live of the County of Santa Clara, Sarah Cody did one of a presentation about this. So as with most communicable diseases, there was contact tracing in the beginning of COVID, but as the disease spreaded to community-wide and we needed to switch to mitigation and surge capacity for the hospitals, contact tracing wasn't as possible. But right now, all of the 6 counties are gearing up for contact tracing. So San Francisco, I think there's somebody on the call for San Mateo County. Yes, everyone is gearing up for training and creating a system so that intense contact tracing can be done. In other countries where they've done that immensely, they've had great results. And that's typically the way that communicable diseases are managed typically. We're in a pandemic now, so we had to shift for a while to kind of save our surge capacity in the hospital, but now they're gearing up for that.
Thank you, Rhonda, for your presentation. We will move on now. As you know, our healthcare system is facing this unprecedented pressure to come up with innovative solutions very fast, and our health communities have been scrambling with guidelines and ensuring appropriate patient care while protecting the healthcare workers. Our next presentations will show us how some of these solutions are being brought to life. We will hear from Claudine Wu. She will talk about simplified video connectivity tailored for patient and family communication, a family perspective. Claudine is a scientist, storyteller, and startup advisor. She has a master's in public health and epidemiology and a PhD in clinical trials methodology and epidemiology from Johns Hopkins. She's also an undergraduate at UC Berkeley, where she began her career in clinical trials. She has helped develop medicines for patients with chronic conditions such as osteoporosis and cardiovascular diseases. She leads workshops and retreats using storytelling to help people connect with themselves and each other. She is grateful I am very grateful to have Claudine in our University of Best Practices, and I am thrilled that she will talk to us about this communication devices. And Claudine.
Thank you so much, Evelyn, and thank you so much to the RightCare leadership for this invitation today. I know everyone is juggling multiple hats, and I want to let you know that I was reminded it's Superheroes Day, and I thank all of you for your heroic efforts during this time. It was a couple of years ago when I received a phone call from my mother, and she said that she had been contacted by her physician's office, and they said they could give her a device that would help her to connect with her doctor. Usually I would pick her up and drive her from her home in Oakland to San Francisco to be seen. And, it's fine. It's a couple of hours depending on traffic in the Bay Area. And I was a little bit surprised that she was open to using this device, because we had tried getting her an iPad and Wi-Fi in her home, but she is very technology naive. She didn't ever really reliably use the iPad, and she doesn't have a smartphone. So I was curious what this device might be. Well, if you go to the next slide, I found this in her living room. It had been set up by someone that was sent over. And what I found out was that her health system was going to be using this as a trial for 1 year with her. They would set up physician visits, and they actually called me to explain that because I was a family member, that I could download an app and be able to use it to call and upload photos and do a sort of sharing. So while it was going to be a tool that her geriatrician could use with her to do home visits, it was also going to be something that she might benefit from in terms of reducing potential isolation, because she does have multiple conditions, and she does live alone by choice. So I was very interested to see how she might do with it. And this device does have its own built-in Wi-Fi, so that was fine. They had also offered it to her in Chinese, but she knew that I would be her IT support should it come down to that. And I don't read Chinese, so she opted for English, which is great. If you go to the next slide, you'll see that this is the representation of the app on the website. And what it allowed me to do was I could actually call her. So in the past, she would feel quite nervous if I was going to be traveling and not available just, to be reached, as she couldn't see me or know where I was. And I was also concerned that she might feel alone. But I had a big trip, an overseas trip that was coming up, and I connected with her doctor to let her know that that was going to be happening. So they arranged for a visit with her during that time. If you go to the next slide, I was actually able to share with her for the first time a video view. So for people who have smartphones across the family, this might not be something novel, but for my mom, it was quite, I think, a surprise to be able to see Tasmania. Which is where I was a couple of years ago when I used this tool with her. So ultimately, it really served her and her doctor to be able to facilitate video visits because she felt comfortable using the tool. It was quite simple. I also found out from their quality person that they were tracking her usage. Again, this was for the trial, but they were tracking her usage of other features, including recipes and articles and music. So again, I think it contributed as much to her healthcare as to her overall well-being. It is available. It is something, I don't have any affiliation with the company, but I do have pricing information on the next slide. Should anyone be interested, just feel free to reach out to me. I think anyone can contact me through the RightCare. Thank you so much for your time and attention.
Thank you, Claudine. We will see if there's any questions from the audience.
I was hoping to help make up time for the agenda. I know if you get off track in the beginning, it's just hopeless at the end. So hopefully we're keeping to time.
Yes, we are, very nicely. Thank you, Claudine. what do you see as we move forward with this epidemic? Do you think these devices would be affordable for our elderly? And how do you see that we could use these for patient care or for families to keep track of their loved ones?
Yeah, thank you, Dr. Scott. Stock, I do believe that this seems like a well-integrated device in the sense that I've seen other individual tools that try to integrate different aspects. So if you're the healthcare provider, sure, you can use Zoom, but it requires your patient to have something that can download Zoom or the Zoom app. If you are a family member, you can buy something that will upload photos and do video, but again, you have to have that willingness and ability to use the device on the other end. So I know that they have a geriatrician who is part of GrandPad. That's the name of the tool. And so I think from that standpoint, they are well aware, and it was specifically designed, you can hear it in the name GrandPad, that it was designed for older adults. So I think given that they have been doing trials within a healthcare system with geriatricians, that it might be something to consider, especially during this time when physical distancing may be contributing to loneliness and isolation.
So we have two questions. One is from Huang Sandu. How does the connectivity work?
Yes, so for the individual with the tablet-like device, they have built-in Wi-Fi. So there's a regular monthly charge that's provided that you would have to subscribe for. And the person calling would simply be using an app and using their own data plan.
Excellent, thank you. So we will now continue our meeting with Intermountain Healthcare Health Partners and Home Monitoring Pilot, shown Dr. Ria Pulicharan, who's the National Medical Director of Population Health and is currently the National Medical Director of Population Health Management and Clinical Outcomes for Healthcare Partners, based in Paso Robles, California. In her current role, she oversees the National Population Health Department for Healthcare Partners Medical Group, and she founded clinical research and the departments for the Healthcare Partners in 2003. She also pioneered the initial design and workflow of the disease management and clinical outcome programs. She has led over 18 years of her career. Dr. Pulicharan, it's a pleasure to have you with us today.
Yes, thank you. Can everyone hear me?
Beautifully, thank you.
Okay, sorry about that because I came prepared, Hattie, to show my face, and my video for some reason, because of privacy or something, it's not working.
Oh, that's a shame. It would be lovely to see you. We miss seeing you.
It's okay, next time. So good afternoon, good evening to everyone. Hope everybody is doing fine during this challenging time. Thank you for giving us this opportunity to present to you the key components of Project Trident. I have my colleague, Dr. Steve Evans here. He will be presenting along with me after my slides. He will come on. He will talk about the ROI, the implementation, the expansion, and the patient and physician journey. And then Kevin Zhao, who is the CTO and founder, is here as well. He will be showing us a live demo of the technology. So the first slide, can I see the first slide? I can't see anything.
We see it clearly.
Yes, I'm thinking, oh God.
Dr. Pulicharan, I'll just tell you what the first slide is, and perhaps you want to just have your slide deck up if you can't see the screen. So the first slide is saying U.S. population health status.
Yes, so I just wanted to talk about the background of why we started Project Trident. So the first reason is because of my position at Healthcare Partners as a population health leader. One of the things that was constantly told to me was I had to make sure that, uh, that we would decrease hospitalization, improve care. And so constantly we were searching for ways to do that. And we found that it was really challenging because initially I thought it should not be that hard. But as I kept, researching and trying to look at things, it was really hard that we could not just call out to patients like our care management were doing and try to see what's going on. We constantly we could not scale it. So we thought, okay, in 2012 we decided to go with maybe a program with remote patient monitoring, use technology. So we decided to do some studies with the congestive heart failure patients. So next slide. So for congestive heart failure patients, when we tried to, do the study, we had to use a lot of internal care pathways, and we could not really focus on, making sure the technology is working well, because we tried different technologies like Philips and Medtronic and all those startup and different, maybe 17 different kinds of technologies. And it was very difficult. We had the care pathways. The patients could not use the technology. The physicians found it hard. It would not connect all the time. And then what happened is we still continued with the study, doing a lot of things manually with our care pathways. And we saw that there was 30% reduction in hospitalization. In the same way for COPD patients as well, we tried, and we found that, again, when we use technology, it was really working well. So in the end, we decided, this is great. There is something in this that we need to research further. So that reminds me of something that Thomas Edison said, when you feel everything is exhausted, you've exhausted all possibilities, you still feel, you should not take it as the last thing. You still have to understand that you haven't exhausted all possibilities. So we were persistent. The team decided we're going to move forward no matter what, and we're going to make sure that this technology, remote patient monitoring, works. So next slide, can someone read it to me?
This is a very beautiful slide, Dr. Pulacharam. This is the wonderful slide that you created called The Potential of Remote Care. And it is talking about the 30% reduction in all-cause admissions that you showed, and it shows your bar chart. And I'm just wondering whether your partner presenters are able to see the slides and possibly take over presenting, since you can't see the slides. I'm just not sure.
Yeah, so maybe Dr. Evans, if you can continue, and then I will catch on. Let me sign back in.
Okay, sure. Thank you for allowing me. Can you hear me okay?
Yes, we are hearing you well.
Okay, so thank you for allowing me to be here. I just want to introduce myself briefly. I am Vice President for Population Health and Senior Medical Director for Quality and for Healthcare Partners in Nevada. So Ria and I—
Thank you for being willing to jump in the middle of a technology glitch.
Sure, I kind of wish I had looked at Ria's slides before this moment, but I think I can do it. Ria and I had been friends for many years, working in different organizations. About 18 months ago, we decided at Healthcare Partners to delve into remote patient monitoring. At that time, I knew that Ria had been the national medical director for Healthcare Partners for research. So I asked her to help me to do a study on remote patient monitoring. If you can go to the next slide.
So I'm back, Dr. Evans.
Okay.
Can everybody
So,
hear me?
yeah, go ahead.
Okay, thank you so much. So basically, I think Dr. Evans explained why we decided to start with Project Trident. So Project Trident, as I discussed, was the result of a lot of failures with different technologies and then trying to not give up and say, we've proven there is positive outcomes and we are saving cost. So there must be a way to do this. So Dr. Evans and I discussed quite a bit and we said, why not start an IRB approved study? And we named it Project Trident. And we said that we are going to use the correct sample size. So nobody is going to poke holes in it. We'll have answers to everything. And then we can give it as a turnkey operation to anyone. So we were also trying different technology organizations again. And we went through the whole list. And we were looking for technology that was smarter, that was intelligent. So we designed the study as the primary objective of the study was to reduce hospital admissions, hospital readmissions, ER visits. Secondary objective was overall healthcare resource utilization, specialized utilization, overall cost. Next slide. So here is the details about the study. So it's IRB approved study, 12-month-long pilot, high-risk patients, 4 or more comorbidities, and 1 hospitalization within the past year. We had 1,200 patients participating, 600 intervention versus 600 control. The beauty of this is we match the cohort. So there's no cherry picking, there's no bias. So we matched both cohorts with age, sex, and comorbidities. And we gave these patients Bluetooth-enabled devices like blood pressure cuff, weighing scale, glucometer, and pulse ox. Next slide. So the vitals we monitored and intervened were on blood pressure, values, weight, blood sugar, pulse rate, pulse oximetry. So what I really wanted to say here is we made sure there is a threshold and we set that threshold for the patient and we said above which or below which we would get an alert. And that alert will be checked to see if it's a real alert. Is it a malfunction of the device? Is it something else? Is a granddaughter taking the reading? So once we know it is the real true alert, patient retakes it again. Patient also, we understand from the patient it's not a malfunction, then we escalate it to a physician who can intervene. Next slide. So the key components were very, very important. So it's a population health management simplified. We called it that because we said, multiple key factors play into the treatment or the management of a patient. One, we need to see, okay, how's the patient living conditions. Is the patient living alone? Do they have a caregiver? Do they have, ways to get their medication? Do they have food to eat? So, and also we wanted to make sure that there is a PharmD doing medication reconciliation. So the technology, which Kevin will show us the live demo, is so fascinating that it had a platform with platform partners. So they had a dietitian, they had the PharmD, they had care management folks, and they had health coaches. They also had certain insulin algorithm software or other algorithms that could tell us certain things. So our providers could do an informed decision when they were intervening. So the insulin algorithm particularly I want to talk about is as we get the blood sugar levels, we are able to compute what is the insulin units that's needed. And the PCPs are able to utilize that and not create more hurdles with the access of endocrinologists. They also had an EMT or paramedic service, for example. So the EMT and paramedic service on the platform, the physician, when they get a true alert, can decide, is this a 911 call or somebody needs to go to the home immediately and check what's going on with the patient. So the EMT service was also integrated into the platform. We also had respiratory therapists who could go to the home of the patient if needed, as they were also integrated. So what I wanted to say was, one thing is we designed it, we had the care pathways and we could automate that. But what is really fascinating was the platform had platform partners, and the dashboard showed us the values immediately. The same time the patient could see the values. At the same time, the whole technology was an intelligent technology. So we could get, certain suggestions, or they did predictive analytics as who's getting worse, who's not taking their reading, what's going on with the patient. So there was so much information that we could learn about the patient surroundings, not just about the healthcare, not just the vitals. We got all this information that made it very comprehensive. Next slide. So here's the results of the 6-month program outcomes. So we saw that 51% reduction in admissions and 51% reduction in admit equivalents called observations, and 52% in ER visits. And this was fascinating because we had never seen such good results with any of our projects in the past. And also this program was different because now not only these great results, but it was also easily scalable. Next slide. So one of the challenges we faced whenever we worked with technology, and I just want to share my own, a lot of my failures, so other people don't repeat those failures, is a lot of technology out there looks fancy. They say a lot of things they can do. And when we try to do all these things, we waste a lot of money. It doesn't work. And I can tell you, I was so embarrassed those days when I had so many of these boxes just kept there and I couldn't utilize them. So it was a really frustrating moment for the organization, for me, for my team, for patients. But what I wanted to say with Project Trident, with Dr. Evans and I, we spent a lot of time making sure that the technology is nimble. They can grow with us. They can learn. We made them go to the homes of the patients, really understand what's missing. So those things really, really made it intelligent, made it the way we need. What we need today is what the technology did for us. So it wasn't just technology. It wasn't just care pathways. It wasn't just knowing what's happening with the patient at home. It was so holistic. And that's the message I want to give here. And I'll leave, next slide, I will leave it to Kevin, who will do a live demo for us and share with us how easy it is to use for these patients, as well as physicians like me who are not technologically savvy.
Thank you, Ria. It's so great to see your face and you got the technology working. Yay!
I know. Finally. Kevin?
Hello. So my name is Kevin Zhao. I'm the CTO and founder of Harmonized. So we're the company that partnered with Healthcare Partners Nevada to try and create these great outcomes. And one of the challenges we faced was really trying to build a technology that's easy for patients to use, but also powerful enough for clinicians to actually make a big impact. So let me share my screen real quick. And I'll give you guys a live demo. Can you guys see my screen?
Yes, we can.
Great. So I'll walk you first in terms of what the patient experience looks like. Each patient gets a box. So on that video, you can see a box that comes in the mail. And then if you open the box, there's a few things that are inside there. So there's some cards that tell you how to get started with the kit. There's a variety of sensors. So you have your pulse oximeters, blood pressure cuff, you have your weight scale, you have glucometer, and then you also have a tablet that comes paired with all the devices. But having a tablet paired with the devices is easy mode. I mean, you can pre-configure anything and it'll work out of the box, but how do you really case for everything that could possibly go wrong? It's a device that breaks, or the patient wants to use their own phone, for example. So what I want to show you is how easy it is for our technology to really connect, agnostically across any kind of device combination, any phone, et cetera. So I have my phone in front of you guys. You can see on the screen. I'm going to show you guys first Bluetooth settings. So you can see I have nothing connected to my phone but my AirPods. So nothing's been set up ahead of time. And then I'm going to go ahead and show you how easy it is to get set up with our technology. So I'm gonna download our app. All right, it's done. And then for each kit, we also have a QR code that allows you to automatically sign in while skipping all of the usual registration processes. So scan this QR code. All right, now the account's already set up, I'm already in. So as a patient, I'm gonna now attempt to use the system. It's built around the concept of one button or one touch. So press one button and it starts the workflow. And I will just go ahead and follow the instructions. So first is pulse oximeter. So I'm gonna go ahead and follow the instructions, put the pulse ox device in my finger, press the button, and then you can already see it's connected to my phone, it's already transmitting. So very, very seamless, automatic connection, everything's set up in the background. So there's no setup required whatsoever. Next is
fast heart rate, Kevin.
I know, I'm nervous. Next is blood pressure. So I'll follow the same instructions, put it around my arm and go ahead and press the button. All right, so I've done it and it's already connected and it's already transmitting. So I don't know if any of you guys have used the Apple AirPods before. I think there's a reason why, they have over 60% market share globally on all headphones. It's not because they look great or they have great design, but it's more so because they work every single time you take them out of the box and put them in your ear. And that's how they kind of skyrocketed in popularity. It's the same principles we designed this after. So everything just works out of the box, no setup required, very easy. Typically, the average elderly high-risk comorbid patient in our system will submit full sets of vitals over 25 times a month. Very, very high adherence, super easy. So I'll wait for the blood pressure to finish measuring. And I think it's taking a little bit longer because my heart rate's probably pumping a little faster than normal. So please bear with me just a sec. All right. So that's blood pressure. Next is weight scale. I'm going to put the weight scale on the ground and take my weight. All right, that's complete. Lastly is glucose. So I'm going to follow the instructions and then do a glucometer measurement. So I take the strip of the glucometer here, put it in the glucometer, and then I actually have control solution here so as to mimic actual real blood. I'm going to put it in. So I got a reading, it says 95. I'm gonna pull out the strip as instructed, click OK, and then done, it's transmitted. So very, very, very simple. And now we have a comprehensive suite of biometric vitals. We also have built-in gamification and reminders, alerts, chat, video, et cetera, that allows patients to be connected with their care provider. And then next is after that's done, the patient is automatically connected to our, what we like to call a triage backend. So what this does is it basically allows a clinical staff to process patients as if they were in a real primary care setting. So we primarily focus on efficiency and efficacy. And there are really four major points. The first is patient encounters. So our system prioritizes patient encounters such as chat, video visits, et cetera, based on patient's alert history, allows them to be processed at scale. The second is clinical workflows. So things like alert triage, medication reconciliation, intervention routing with smooth warm transfers between medical staff. We, as Dr. Ria mentioned, we also integrate a variety of platform partners, like health coaches and ENT services. And lastly, we do a lot of resource optimization. So determining the level of medical staff needed to handle each particular case. whether they range from medical assistants all the way to doctors and physicians. And we also provide suggested guidance based on each patient's alert history. And I'll paint a very quick example of what this looks like. So I have some clones here of real patient data, de-identified through our portal. So you can see here, you have standard biometric vitals, and you have a variety of rich data. But what makes our system special is we track all the encounters and in triage that happens to a patient. For example, here, triage is not a simple process that involves one medical assistant going end to end all the way through. It involves a lot of handoff between a lot of different medical staff. And we track all these transactions and we make it very visible for all people. So patients don't have to keep on doing explaining over and over again when they get transferred to another medical assistant or whatnot. Here, for example, this is a good example because it shows all the way from medical assistant to doctor, and then even to one of our platform partners. So here you can see our emergency EMT platform partner went to the patient's home, found that the oxygen tubing was tangled, and then untangled it. And in around 5 minutes, the patient's oxygen level had recovered. And this, if not addressed earlier, could be catastrophic and lead to an ICU visit and potentially worse, so to speak. So these alert trees that really keep track of each stakeholder that gets on the system is really important to mimic a real hospital workflow. All right, I'll stop there.
Thank you, Kevin. Ria, are you going to be speaking next to address the question from Dr. Yu?
Dr. Evans was going to continue with the presentation.
Okay.
We were not done. So Dr. Evans, are you going to continue? So next slide,
sure.
Brian.
Sure. How much time do we have left?
We have about
7 minutes.
I'm sorry, 1 minute?
7 minutes.
Oh, okay, very good. So let's go to the next slide then. So as Ria mentioned, our preliminary data on patients who had completed 6 months with the platform and the app showed a 51% reduction in admissions and 52% reduction in ER visits. This is, as Ria had stated, this is more than I had seen in the past. And so we figured that there was probably something to the differences we had put into this program. When we calculated the ROI, it's because, in order to expand this, it's necessary for me to show that, in fact, we're not losing a lot of money since we're a company that has to survive on premiums and such. So when we calculated the ROI, it was a pretty dramatic 7 to 1 based on the amount of money that we'd spent with Harmonize and on salaries, etc. So next slide. Some of the interventions that I'll go through, I think Kevin has already talked about, but the low-level interventions, they happen pretty much before the alerts get escalated to a medical director and healthcare partners. They happen at the Harmonize level. Harmonize has health coaches and other specialists, such as dietitians, pharmacists, that will interact for an alert before the alert ever gets escalated. There's a triage staff that is part of what we have partnered with Harmonize for, and they actually are employed by Harmonize. And they are able to triage the alerts, determine whether or not it's an equipment issue, whether or not it's a true alert, determine whether or not a patient needs a dietitian. If in fact the alert needs to be passed on to a medical director at Healthcare Partners, that is done via the portal, the Harmonized Portal. And the medical director who is on call for this will get a text as well as an email. We actually started out, when we started the program, we had a part-time doctor that was taking care of these, and then a bunch of the medical directors that work with me would pitch in when the alerts got to be too much. We ended up deciding that we'd use a full-time medical director to manage these alerts 7 days a week. Some of the medium level, what we call the home interventions are, we do send home health services out, as well as the ready responders and dispatch health type organizations act as urgent care providers. And then lastly, our primary care doctors at Healthcare Partners do get a monthly summary of what Kevin just showed you in terms of the vital signs. In addition, anytime there's an intervention that's made, we do what's called a task to the primary care provider, as well as to the patient's case manager. And we try and coordinate the care as much as possible through that process. You can go on to the next slide. I wanted to mention some real patient outcomes. First one was, patient with diabetes, hypertension, CHF. The patient had a problem in that their weight was increased slightly. They alerted the Harmonized triage staff, called the patient, and the patient volunteered that they had swelling in their lower extremities. So that alert was sent on to our medical director, and a medical director was able to call the patient, talk to the patient, determine that the patient had not in fact been taking their diuretics as prescribed. They were able to titrate up the medication, and I believe probably saved the patient from having to go to the ER. Patient ended up doing fine. Second patient, AFib, CHF, hypertension, increase in the blood pressure. And it turned out that the patient was not adhering to their diet as they should, and had way too much salt in their diet. So in addition to increasing the medications, we also connected to a dietitian, and within about a week, the blood pressure was under control. And then the last case is, I think Kevin already demonstrated that one. That's one where the patient's saturation was 85, I believe. And so it alerted the triage team, called. They had him recheck this pulse oximeter, sent on to the medical director. And we ended up, because the patient normally had a saturation in the 90s, we sent an EMT out, determined that in fact the patient was not getting oxygen. The patient did end up wanting to go to the ER because they didn't feel good because of that, but probably we did save the patient from a worse outcome. If you go to the next slide. Some of the add-ons that I wanted to mention that we've encountered with the Harmonized Portal and app and company that we didn't get. At first, I had contracted with Medtronic, and I was going to do this all remote monitoring with Medtronic. I quickly learned that it is not very customizable when you work with a very, very large corporation like Medtronic. And so some of these add-ons are things that we have asked Harmonized to give us during the time that we've been in partnership with them. Some of the important ones I'll just mention briefly. The gamification. We give patients little trophies on their phones for taking their vital signs a certain number of times. We actually have them compete against each other in different areas of the city. We're able to individualize schedules. Some patients just refuse to take their vital signs every day, and if it means getting off the program or compromising and saying it's every 3 days, we are able to do that. And same thing with customizable alert. Some patients, you're never going to get their glucose less than 160, and if you keep alerting at 140, then every day they'll alert and they'll want to get rid of the program. So we're able to customize that. We use TouchWorks at Healthcare Partners, and we were able to integrate the data that's in the app into our TouchWorks EHR. Another important point is we start out with Wi-Fi, and in fact, when Kevin and his team brought these boxes to the patients, they would attempt to hook up to the patient's Wi-Fi. In Las Vegas, which is our service area, there's many areas where the seniors don't have reliable or even any Wi-Fi connections. So within about 2 weeks, we decided that we were going to change to cellular data. So now all the tablets that the patients use have SIM cards that Harmonized provides, and the data is all uploaded via cellular data. And then the health coaches, the dietitians, the pharmacists, we've already talked about that. And then the open the box and play. that's real. That's true. When I was trying to sell this to my CEO, I took a big gamble, kind of like Kevin just did. And I took a box, I opened it up, and I made our CEO go through the process. He did it in about 5 minutes, and that's when they agreed to give us the money to start the program. And then next slide. One thing I do want to mention is that this is expandable. So what we've talked about so far is a IRB approved study called Trident, and we're going to publish this data hopefully within the next 8 months or so. But we've been able to look at the data, the preliminary data, and said, you know, this is pretty remarkable that we're able to keep patients out of the hospital. So as the flu season was coming up, we decided to expand the program. We added another 2,000 patients to the group of patients that got the monitors for the flu season. In addition, Harmonized made sure that they all got flu shots. If they didn't have hadn't been gotten flu shots, Harmonized either arranged for the flu shot in their home, or they arranged for them to come and get a flu shot at one of our facilities. And we targeted patients with CHF and COPD for this. We don't have any data yet on this, as the flu season is, you know, just now winding down. But I'll tell you, the other thing that we did was that as the COVID-19 pandemic appeared to us, we said, how to use this same technology for the current situation. And it was just not possible for us monitors and to be able to expand in the way that we did with Project Trident and the flu extension. We're not able to get, you know, we have 75,000 Medicare full risk, Medicare Advantage lives. And I said, let's give everybody this during the COVID-19 crisis. But we're not able to get that sort of number. So we actually pivoted and we took the same app and we turned it into what we call our COVID-19 app. And we did in fact give it to all 75,000 patients. And what we monitor with that is temperature. We do push notifications for the patients to take their temperature, as well as push notifications to answer questions about any symptoms they may have for COVID-19. We have the patients submit their data every morning or whenever they want to, whenever they feel like they have symptoms. And so far, our data shows that we have about a 20% of the time patients, when they have what we call an alert from this data, either a temperature over the threshold or any of the symptoms of COVID-19, about 20% of the time we make some sort of meaningful intervention. So we might have them tested, we might urgent care provider show up to their house, or we might bring them into our clinics. And so here's the last thing I'll talk about is, this is a patient story from, I think it was about the first or second week that we did the COVID-19 app. 72-year-old lady with COPD, CHF, diabetes. She had a temperature of 101.6, I believe, and she did have a cough. The triage people, staff from Harmonized called, determined that the patient had been in the emergency room 3 days before, had been tested but didn't have results yet, and this cough was relatively new, 9 days, and it was productive, shortness of breath. And the patient was very concerned, and they said they were going to go back to the ER that. So our medical director called the patient. In the meantime, since the time that we had done the flu extension to the COVID-19, we had developed a video capability with Kevin's team. And so most of our visits now are video visits. Our medical director was able to video call the patient, reassured the patient, determined that the patient probably had bronchitis, or at least could use some antibiotics at that point, as well as the medical director prescribed Tamiflu for the patient. Checked on the COVID-19 test for the next 2 days, came back negative, ended up doing fine within 2 or 3 days after that. That is all I have. I spoke fast because that 7 minutes scared me.
Thank you, Dr. Evans. That was an amazing presentation. As we hear how these technologies help us both avoid near misses and triage patients effectively, and have them treated at home, almost providing a physician at home kind of approach. We will move on now to from that story to to PharmD Marilyn Stebbins, who's a professor at the Department of Clinical Pharmacy, who we are so lucky to have today. She's a COVID-19 survivor and also a UCSF clinical pharmacy professor and telehealth leader. Dr. Stebbins has been a faculty member of our School of Pharmacy since 1998, and presently she's the vice chair of clinical innovation, and she works hard to develop innovative team-based practice models in ambulatory and community pharmacy settings. Dr. Stebbins, we are so happy to have you with us and share your story with us.
Thank you, Dr. Stock. Can you all hear me? I'm assuming the answer is yes.
Yes, we can.
Okay. Well, as Dr. Stock stated, my name's Marilyn Stebbins, and I am patient number 69, COVID patient number 69 in the country. And so I think most of you know we are over 1 million cases. And so I was a very early case. And I'd just like to maybe discuss a little bit about my COVID journey as both a patient and a provider, and maybe share with you some of the learnings that I had, as well as the experience that I had. I also just want to let you know, I know we are 15 minutes. I've documented my story and published it on social media as well as on the UCSF website. So I'm happy to share, because I think that it's really important for people to hear from COVID survivors and hear about their journey. Just to start it off, again, being very early, my symptoms started at the end of February. I am a very active 58-year-old. I'm an ultra marathoner. So the week before I got sick, I did a 30K trail run in the Marin Headlands and was going to be doing a 50K race the week after I was diagnosed, and happened to be on a ski trip up in northern Idaho, not Sun Valley, but northern Idaho when my symptoms started. So it's very hard for me to know where I actually picked up the virus. I thought my first symptoms were actually when I was in Idaho, but as I reflect back, I did have mild cold symptoms the day before I left on my ski trip. But I have to say, it didn't dampen the ski trip at all. We had 3 days of fresh powder skiing, and on the last day, I asked my husband and my brother-in-law, who I was skiing with, if either of them were experiencing burning in their lungs. And both of them said no, but they weren't surprised because we'd been skiing really hard. We were at the end of our 3rd day and we were skiing far more than we normally ski. We were skiing about 6 to 7 hours a day. And so they just, chalked it up to exertion. I figured it was altitude, cold air, and that was my burning lungs. The next day, got ready to go home and fly home. I flew in and out of Spokane. So that was right when Seattle was erupting or beginning to see its cases of COVID. And but I was flying in and out of Spokane. And as we were driving to the airport, I suddenly was struck with very intense GI symptoms of diarrhea and nausea, and had a forced stop because I just was feeling so sick from it, and thought I actually had food poisoning. That continued for the rest of that day. Got home about 1 o'clock in the afternoon, and my vanity set in and thought I had food poisoning, thought it was settling down, but I had broken a couple of fingernails on my ski trip. So I took a trip to the manicurist and sat a foot away from my manicurist, who, thank goodness, had a mask on, who touched my hands for an hour, and proceeded to go home. And at that point, really my symptoms were GI symptoms. Woke up the next morning and said, oh my God, I have the flu. Still, COVID did not even enter my mind. But I was sick enough, and I'm not one that ever goes to the doctor, that I called my doctor to ask to be seen because I was sure I had the flu. I had every classic symptom of myalgias. I had a cough. I just, the one thing I didn't have, and I didn't have through my entire bout with COVID, was a fever. But my lungs were burning, and my primary care provider said, I don't have any appointments available today, but I really want you to go to the emergency room and get a chest x-ray. So I went to the ER, very begrudgingly. I begged her to let me just go to an urgent care because I did not want to sit in the ER because I felt so horrible. My GI symptoms continued, got to the ER, that was not taking any precautions. There was no PPE. They did ask me whether or not I had any contact with anyone from China, had I traveled internationally, and did I have a fever? And all of those were negative. So obviously I wasn't tested for COVID at that point. But my chest x-ray, they came back and said, you know, this chest x-ray is very surprising because it's extremely extensive. You have multifocal pneumonia, and you look pretty darn good, and your vital signs are good. And my pulse ox was 99. So they said, but we are going to give you antibiotics for community acquired pneumonia, and we really want you to see your doctor within a week because your chest x-ray is scary for something more than just pneumonia. There's something underlying this. And they even mentioned the word malignancy, which terrified me because I am a breast cancer survivor. So that was unsettling. So I immediately went home and charted my doctor, who said, I'll see you Monday morning or Monday. And I got an afternoon appointment. So I got my antibiotics, went home. Actually, before I left, I begged them to test me for the flu, although I'd had a flu shot, because I felt incredibly viral. Every symptom was a viral symptom. And so I tested negative for the flu and went home like a good pharmacist. I took both doses of my Augmentin that day and got in my azithromycin and went to bed, and literally spent about 20 hours in bed that weekend. And I got progressively worse. And I knew that if I had bacterial pneumonia, I should be getting better. Even with 24 hours of antibiotic, I should be feeling somewhat better. And I just continued to get worse. I couldn't get off the couch, get out of bed. I couldn't climb my stairs. I was really struggling. And I have family members who are healthcare providers who were encouraging me on Sunday to go to the ER. And I said, nope, I am actually going to the doctor tomorrow. I'm not going back to the ER. And so the next day I had an appointment in the afternoon with my doctor, who did a repeat chest x-ray, which showed not surprisingly, the same multifocal pneumonia bilaterally. And but at that point, my pulse ox was down to 93, and she was starting to get concerned because I looked so sick. And she said, look, I think you need to have a very low tolerance for going to the emergency room, but go to UC Davis in Sacramento. And I live in Davis. So I went home, and it took about an hour for me to look at my husband and say, could you please take me to the emergency room? I'm really sick. So I went to the emergency room that night about 7:30, and that was Monday, March 2nd. And again, people were not all in, there was PPE was not around. I think my one nurse was masked, but all my intake folks weren't. I basically, thank goodness, was given fluids and oxygen and felt better. But it wasn't until I actually got some Dilaudid that my coughing stopped, and I actually felt like I went into another world. It actually was quite a good feeling because it hurt so badly to breathe at that point. And I would trigger with coughing, burning lungs, then I would get intense nausea, headache, and diarrhea. And it was just a cycle that was really vicious. So they swabbed me. First of all, they did blood cultures, gave me more antibiotics, ceftriaxone and IV augmentin or azithromycin, did a viral panel for everything, blood cultures, you know, did all of the classics for sepsis, so my procalcitonin, and everything came back negative. I was leukopenic and lymphopenic, and my pulse ox was down to about 90 at this point, and would drop whenever I'd have, obviously, a coughing spell. So I was admitted to a funny area of an emergency room that was a reverse airflow room, and an infectious disease consult was called. And I spent the night in that room, and then the next morning I had an ID consult. But interestingly, I still didn't meet criteria for COVID testing because I didn't have a fever. So they admitted me to the hospital because guess what? If you were admitted to the hospital, you could get rid of that fever criteria. And so UC Davis was able to test me for COVID. The second they tested me for COVID, my life changed. Everyone got into PPE, and PPE then were the respirators because they still were looking at it as aerosolized and not just droplet based. And so everyone, all of my nurses had respirators, the beekeeping suits. I never saw my husband again for the next 8 days. And I was admitted, not admitted to the hospital yet, because they were waiting for my test results. I was in a long-term
5 minutes.
PD. So I quickly, that evening, my test came back positive, and I was put into the intensive care unit, more because they were hearing all the horror stories of people taking that horrible downturn very quickly, where their pulse ox would just drop and they'd be talking and fine, but need to be intubated. So they put me in the ICU and continued supportive care. I never, thank goodness, took that turn. I stayed on oxygen for 4 days and continued with supportive care. And interestingly, we discussed some of the drugs at that point, and determined that I wasn't going to use them because at that point they were only using them in their most severe patients, and it looked like I wasn't going to take that turn. So the next point was, how do we get her home? They didn't have a section of their hospital that I could be transferred to sort of stabilize. I was, after 7 days, I tested positive still. So they were trying to figure out how to get me home. That's a crazy story because I ended up going from the ICU directly to driving myself in my own car home. I had to find a way to get my car to the hospital and get it home. And so literally it was very surreal to have 8 days in the hospital and then be driving yourself home. And then it was, what do I do with my husband? He had been quarantined at that point, but now we had to isolate from one another. And now I was the responsibility of my local county public health, who I didn't hear from for 4 days, who also released a press release calling me an older woman with underlying health conditions. And I asked for it to be changed because I didn't think that represented who I was. And at that point, we weren't seeing healthy people get COVID and end up in an ICU. And I thought it was really disingenuous to present that to the public because anyone who knew me, who saw the press release, really believed that I was some elderly woman in a nursing home, which obviously wasn't me. So I struggled with public health, who again did not contact me for 4 days when I got home. I didn't know where I was going next. Was I being tested? Could my husband be tested? What was my husband's isolation status? When they did call me, they told me my husband could come out of isolation. And I said, but I'm testing positive and he's in the same home with me. Granted, I was isolated to a bedroom and a bathroom, but it didn't make sense to release him out into the public because we weren't in shelter in place. So I didn't feel like I got very good guidance and struggled with that. The fortunate thing is I have a phenomenal primary care provider who worked very hard with me to figure out what to do. Interestingly, I've been testing positive ever since. I had a negative test 10 days ago, and my confirmatory test after that came up positive. So I'm 50 some days into COVID. I was tested again yesterday, and my test, I just got it back before this call, came back negative or non-reactive. So I'm testing again tomorrow. But I think the lessons that I'd like to bear to mind are from an early patient is I really understand. I had phenomenal care in the hospital. I didn't have as phenomenal care when I went home. The transition to home is very difficult for patients anytime. And with COVID, it is even worse because your risk of infecting your family or your caregivers is high. And I was an educated healthcare provider and I couldn't find answers. And at that point, everything was changing. The CDC was changing guidance. Sacramento County and Yolo County had different guidance. So it was very difficult to navigate the system. And it was very isolating. I felt completely alone when I went home. You go from an ICU where they care for you 100% 24/7 to going home where you have no one to care for you and you're still sick. So I think that the lessons that I learned is we need a learning healthcare system and that means down from the CDC to our local public health to all of our health systems, that we learn to say we don't know, but I'll try to find out for you because knowledge is power and patients have no knowledge. And it was frustrating for me who felt she had knowledge because the knowledge wasn't even out there at that point. So I think really talking to our patients who are scared, encouraging people to join studies. I know I've been involved now in several antibody studies, and as soon as I test negative twice, I get to donate my convalescent plasma. So I'm waiting for that. And I think we all need to engage in the research that's out there. Probably one of the most exciting times in science is right now because everything is so rapid. That has its pluses and minuses, but it's really a tremendous time for science. So being involved as scientists is really important, but not forgetting about our patients and remembering patient-centered care. And also remembering each day to look and say, what can I do differently tomorrow based upon what I learned today? And I think that's the way we need to treat this pandemic because we're learning new things every day. And I'm going to stop there, Hattie, because I think I'm over time anyway.
Marilyn, thank you so much for, surviving one. You're one of our, key RightCare family members. And it just, I started shaking and crying when I read your story. And I was, and I see that my internet is a little unstable. So can you hear me?
Mm-hmm. I can.
Well, I really appreciate your bringing your scientific mind back to the collaborative to help with others who are leading health systems and trying to work their way through how to improve things. Also, from the standpoint of just the cycle you've described, where you had a negative test, but then it went positive again. And I think the whole community, as you said previously, is learning to fly the plane while building it. So really appreciate you, especially connecting with Dr. Joe Skye, who our Air Force guy, the chief of cardiology for Travis, to help work on that antibody testing issue. And anyway, I'm so glad that you are better, but I understand that it's a long climb back. And
but I am running again. I actually found a deserted trail so that I could get myself back in shape. And so I'm only at 3 miles, but I think I attribute my positive ICU outcome from my previous good aerobic health.
Excellent. Thank you, Marilyn. It's heartwarming and at the same time a little devastating to hear your story. Taking, your example of somebody who confronted this while being healthy. We will move on to our next speaker, who is going to talk to us about smoking cessation and the COVID-19, as you probably experienced. I found quote from the American Lung Association saying their motto is, when you can't breathe, nothing else matters.
Very true.
So I am thrilled to introduce Dr. Elisa Tong, who is Associate Professor of Medicine at UC Davis Health and Project Director of California Quits. Dr. Tong, I welcome you to our meeting, and we're thrilled and anxious.
Great. Thank you. Can everyone hear me? Yes, next slide.
Yes, we can.
Perfect.
Okay. Well, thanks everyone. I'm delighted to speak at today's RightCare Initiative meeting. As all my education and training has been in the Bay Area, from Stanford to Santa Clara Valley for residency and UCSF for fellowship, including on tobacco control. So, I'm at UC Davis, and glad to hear Marilyn did well at UC Davis too. It's my hometown of Sacramento. So anyways, my research is in tobacco control policy and cessation. So one of my projects is California Quits, which is a statewide tobacco learning collaborative funded by the California Tobacco Control Program. I also have projects for integrating tobacco treatment with our cancer center as part of the National Cancer Institute Cancer Center Cessation Initiative. And I also have this tobacco-related disease research program research project with Los Angeles County Department of Health Services. So I'll touch a little bit on those at the end. But I understand that it's a very timely topic of smoking cessation and COVID. Next. So here's a brief overview of what I'd like to present today. First, I'll talk about the risks with smoking and COVID, what we know, what we are learning. Second, I'll talk about smoking cessation issues in general for patients and providers as we all try to adapt to staying at home. And third, I'll talk about how we can move forward with population health and utilize our free state quit line, the California Smokers Helpline. Next. So as COVID unfolded, I was getting a lot of questions about the relationship with smoking. What do we know about it? So I reached out to the California Tobacco Control Program, asking how can I help educate as a physician, as a tobacco control researcher. And so I helped them post this article on their public website, tobaccofreeca.com. And so that's a little quote there that they took out, and there's a little part of the letter on the right where I talk about 3 reasons for someone to stop smoking and vaping now. And then there's some call to action at the end about resources to help quit and keep a smoke-free home. And I'll touch on that later too. Next. So reason number 1, smoking doubles the risk of respiratory infections. It was actually a retired colleague who reminded me about this very interesting clinical trial published in the 90s in the American Journal of Public Health, And I don't know if they're ever going to do this study again, but in the trial, 391 healthy volunteers had respiratory viruses dropped into their noses with saline. And so this also included a coronavirus as well, of course, not the current one, but there were these different viruses. So the subjects and investigators were actually blinded to the assessment process and the purpose of the studies. And the subjects were actually quarantined after they received this virus challenge. And so a clinician, and this is the UK, they examined the subjects daily for 6 days after the challenge. And then they also saw their regular doc about a month after the challenge as well. And so they did a whole bunch of different studies, including mucus weights, which does not sound like a great lab job to have. But the volunteers who smoked were twice as likely as those who did not smoke to develop a respiratory infection. So in the trial, there are about 100 smokers or so. They looked even to see, did cigarettes per day matter? And it really didn't make that much of a difference whether you were over a half pack a day or not. And they also did biochemical validation with cotinine, which is a nicotine metabolite that you can measure by blood or serum or urine. And so they were also able to biochemically validate if they were a smoker as well. So very strong evidence about from this clinical trial that smoking doubles the risk of respiratory infections. Next. So not just this study, but a whole body of studies that you can see in the 2014 Surgeon General's report. They reviewed all this biologic and epidemiologic evidence, and they concluded that smoking increases the risk for respiratory infections. So it wasn't just this cold study, but there are other infections, for example, like tuberculosis. And you can see here, this is a public fact sheet. The explanation here about how the toxic smoke affects cells and tissue, and then you can, with repeated exposure, you can get chronic lung disease over time. And then very interestingly, in the 2014 Surgeon General's report also was that it included the conclusion that smoking harms the immune system and can make the body less successful at fighting disease. And notably, that includes things like cold and flu viruses, but also other conditions such as cancer and even autoimmune disorders like rheumatoid arthritis. So this is the report where they start saying smoking causes things like rheumatoid arthritis and other autoimmune diseases. So you can look at the full report for the detailed review of all these studies that support these two conclusions. Next. So reason number 2, smoking seems to double the risk of getting sicker with COVID. So this was a systematic review published in Tobacco-Induced Diseases last month. And so as things were starting to come up, the clinical studies were coming out of China, they looked at some of those studies, 5 of these studies that reported data on the smoking status of patients infected with COVID. And so from that published data, the authors calculated that smokers were over 2 times more likely to get sicker, that is to be admitted to an ICU, need mechanical ventilation, or die compared to non-smokers. And at the conclusion at the end, they acknowledge, of course, there's more research needs to be done, but smoking is most likely associated with worse outcomes. So let's take a look next at the study that supports this. So this is the Guan study from New England Journal that is the largest study about clinical characteristics of COVID patients in China. And so let me walk you through what they meant about the data being recalculated. So when you look at the black box, if you look down at the columns, you can see maybe what we might be typically used to hearing about, what's the prevalence of smokers in this study population. So here you can see that they say that current smokers amongst these over 1,000 patients were 12.6%, and former smokers were almost 2%. And it's been noted also in the lay press, and other folks have commented, well, this seems like a lot lower than the general smoking prevalence in China, where half of the men smoke and the women don't smoke very much at all. But we'll talk about that a little bit more in a minute. But if you recalculate the data, so what they did was they took those numbers in those red boxes, and if you look by row across never smokers, former smokers, and current smokers, and you look at the outcome of disease severity or presence of the primary composite endpoint, and that composite endpoint was needing ICU, mechanical ventilation, or dying, you can see that the former and current smokers, if you look within their group, had higher rates of these severe outcomes. So I know it's a lot to take in, but just want to show you it's very important which way you look at the data, columns or rows. Next. And then in the US, just wanted to share also the early MMWR report about what do COVID patients in the US start looking like. And you can see here that there's a number of patients, but a lot of missing data. And so they were only able to look at about 7,000 patients or so that had information. So we can see the same sort of thing where they try to get the percent of conditions represented in this sample, including chronic disease, all of which are also related to tobacco. And then while this paper is focusing on clinical characteristics, it's also important to note the smoking status here, and this is definitely lower than what's reported in the general population when you take surveys of healthy people, but you know, look also across the same way to see what are the risks of outcomes for the outcomes of interest as to who gets sicker. So as more data comes in, you know, it's important to keep in mind how to look at this data. Next. So I couldn't resist putting this in because it's been getting a lot of press, and it even showed up in the San Francisco Chronicle, which I do check from time to time. And I just couldn't resist looking at the headline, "Smoking may protect you against COVID." And you know, this was something also where the World Health Organization has actually had to put out statements saying, you know, smoking does not protect you from disease. But you know, just taking a closer look at what this study, or what's the description of this study saying, is that there was a French hospital report saying that there were not that many smokers in this sample compared to the general public. And so this study is also not in the peer-reviewed literature. It's published in an open science platform. But the conclusion is that they think that maybe smoking is protective. And I'm not sure if this is a distortion of what the authors wrote, but it brings to mind when you're looking at the data, think again about the source of how people are collecting data during this time with people who are hospitalized and sick. I myself, when I've been an attending in the hospital, supervising the medicine residents, I've seen a medicine resident ask a patient, "Do you smoke?" And the patient said no. But when I went and asked the patient, "When was the last time you smoked?" they said last week, because they were not feeling that sick still, and they were able to smoke. So it all depends on how you ask the question, and you can get very different responses on how you ask. It's also not mandatory or standardized the way people ask in the hospital. So it's also, there's quality metric for hospitals on tobacco, but it's still voluntary with the Joint Commission. So just consider how to think about the data when you see headlines like this and how it's represented when you read the news. Next. Well, finally, reason number 3, vaping can also harm lung health. So a news reporter from KQED actually reached out to me about this 21-year-old who had been regularly vaping nicotine before he got hospitalized for several days, really sick with COVID. So, you know, we are finding out that COVID does affect young people as well. Next. So you may already know about this, but you know, this past year we were seeing an unprecedented epidemic of EVALI, which is e-cigarette vaping associated lung injury, and also a youth vaping epidemic thought to be brought on by new products with nicotine salts such as Juul. So from last summer, you can see there were almost 3,000 people hospitalized. And this is just hospitalizations. There are, you know, many more people walking around who weren't that sick to go to the hospital. And the median age of these patients was 24 years. Unfortunately, the people who were passing away were older. I think they were almost 60 years old or so. And then when they asked folks what did they use in the epidemiologic investigation, a large proportion of them said THC, which is the psychoactive component of marijuana, and over half used nicotine, but very few said that they used one solely by itself. And in the investigation, it's noted that they're instructing doctors, you need to ask the past 3 months of use. And so it's not even the past week, the past month. They were asking people, please collect the past 90 days of exposure. So are we doing that as clinicians, are we asking that regularly, even about people if they're vaping? This is such a brand new phenomenon. We're not even at that stage yet to integrate it into our workflows. So you may have also heard that that vitamin E is a culprit of this, but just recognize that that's a small study of about 50 people who had the bronchoscopic lavage done. And vitamin E is thought to be a filler agent that looks like THC. So there's still a lot that we need to learn about how heated chemicals and particulates lead to lung injury. Next. I just want to note also how similar EVALI signs and symptoms can be compared to with what we're hearing about with COVID, and even Marilyn's story about how she had GI symptoms first before all the lung burning. You know, as a clinician, you see a patient like that, and what do you think of? You know, I tried to get this patient flyer from the CDC about EVALI symptoms that were respiratory, GI, and also constitutional symptoms. For them to put this up in the emergency department, and they actually refused because they said this is all very non-specific, and you know, a lot of people have these symptoms. So it can also be very difficult to tell what's going on, especially might be easier to tell with a young person with healthy lungs if they have no other problems, but it can be very difficult to diagnose this. And this little blurb on the right-hand side just shows some of the descriptions of what they see on a clinical and pathologic scale for when people have lung injury from vaping. So it's really what we call a diagnosis of exclusion. They have to rule everything out. So if you can imagine someone needing to get tested for COVID, it comes back negative maybe the first time for whatever reason, or you know, only later does it turn positive. It can be very complicated. And so if you want to learn more about this present clinical presentation, we actually had a presentation at UC Davis where the mother of this patient presented about his course and how it was actually a Kaiser, a local Kaiser here. And it was really difficult for them to make a diagnosis, but luckily he survived. So it's a very fascinating story for if you watch the first 15 minutes of the video at the bottom. Next. So for more information, because I know this could be a lot longer of a talk, but the California Tobacco Control Program is posting information that's very patient-friendly and also public-friendly. So not just that tobaccofreeca.com, but I do have the URL for this website. And notably, Stanford, I think, helped to make this very nice 1-minute video that's on their website that just shows visually what happens when lungs are exposed to COVID. And it doesn't have any voiceover at all, but it can be something that's very helpful for people with low health literacy. There's also a nice frequently asked questions to the right-hand side and additional resources, including the article that I had talked to you about before. Okay, next. So let's pivot a little bit here about the patient and provider impact for smoking cessation. I'll just touch a little bit about smokers and non-smokers and also for providers. And I recognize that maybe not everybody has the same background of information about smoking cessation. So I'll just include a little bit of information which is also adapted from UCSF's Pharmacy School of Pharmacy's RX for Change. Next. So here's a slide from UCSF's RX for Change, where just remember, how do people become dependent on tobacco? It's a two-part problem. And when you break it down like this, it makes it a little bit easier to think about and manage. So one is the addiction to nicotine, which is one of the most addictive chemicals. And so it is also hardwired in with people's behaviors and routines in terms of using tobacco. You know, a lot of times you hear people say, I always smoke after dinner or when I'm on the phone or whatnot. And so that gets hardwired together. And how do you unpack that? How do you help someone unlearn that? There are medications to help, and then there's also behavior change programs that help people understand their triggers, their motivations, their coping strategies, and the California Smokers Helpline is one of those behavior change programs. And in terms of how many times it takes for someone to quit, it can take 8 to 12 times for people to quit for good. Next. Back one about nicotine withdrawal. So nicotine, as I was saying, is highly addictive, and the tobacco industry, from all their documents, it's been known that they have chemically changed the cigarette so that it's much more easily absorbed. They basically freebased the nicotine so that it's easier to absorb when you inhale a cigarette. So you get a much faster dose of nicotine than you do from any of the medications that are out there. And when people withdraw from nicotine, these are some of the symptoms that they might experience when they don't have that. And now there's these new nicotine salt products, Juul being one of them, the Juul looking like the USB flash drive device, and now there's new ones that are single-use disposable ones like Puff Bar. But they have, there's an interesting story about how the manufacturers went to the tobacco industry documents and found some of the scientists' information about how to create nicotine salts. And so really what it is it's a way that it's for people to have nicotine much more easily available in their bodies. They don't have the same sort of feeling of sickness, of nausea when they take in too much nicotine. And so 1 pack of cigarettes is thought to be equivalent to 1 pod of these flavor pods that you would put into one of these devices. So there are some patients who don't even realize how much they're consuming, especially since they're flavored as well. And so there are people who are even consuming 3 to 4 of these pods a day. Next. So as we're thinking about everybody being at home, here are some of my concerns, because when I talk to smokers in the clinic, you know, I just even had one a week or two ago that this is really not a good time. I'm really stressed. I just can't deal with this. This is the last thing I want to do. We know it leaves stress for folks, but if anything, you know, how do we talk to them about this to motivate them? But so here are some of the things that I think about when I'm talking to somebody at home. You know, about stress, anxiety, depression, weight concerns, especially if you're, you know, eating a lot at home and not being able to move outside very much. Interestingly, you know, some of the LGBTQ community has been talking about how self-harm sometimes is tied into their community's use of tobacco as well, where, you know, it's somehow a relief to be able to use tobacco. Of course, you have the teens who might be bored or experimenting at home while you have distance learning going on without school supervision. And then folks who feel isolated. If you've ever heard of someone saying, you know, the cigarette's my best friend, you know, what is that like to feel all alone where you live? And then when people are encountering us in the clinic, you know, we've moved to telephone encounters, to video visits. We don't have the same workflow right now of a medical assistant taking your vitals, asking about your tobacco status. We're just kind of zeroing in right on what is the main problem that I can help you with remotely. And there's also a concern for delay in care too. I know the head of our emergency department is, you know, and other folks have been like, where are all the heart attacks going? where, you know, are we going to see a big wave of people who've delayed care and now they're even sicker? So these are all some of the things I think about when I encounter folks now through the clinic system. Next. And then it's not just patients who smoke or use tobacco, it's also the non-smokers as well. When you're at home, you may also have increased exposure because of other household members living in the house who smoke. There's also something called third-hand smoke, which is from the pediatric literature, but it's talking about the residual nicotine and chemicals on clothing and surfaces that off-gases, and that keeps, as the chemicals keep reacting in the environment, they actually get more toxic per gram. And then if you live in multi-unit housing, you also have shared ventilation with your neighbors through the pipes, the electrical lines. You know, even if they go outside to smoke, it may come in through the vents. So the Surgeon General has also determined there's no safe level of secondhand smoke exposure. This is another thing we should think about. Next. So if for folks who haven't heard about tobacco treatment before, just want to let you know there is something called the 5 A's for providers to address tobacco systematically. And then the shortcut way, which is championed also by Steve Schroeder at UCSF, is the Ask, Advise, Refer model for busy providers to refer to a Quitline or other resource. So asking about tobacco use and exposure, which again, I mentioned is not quite being done these days, advising about tobacco users to quit. What do you say in a timely manner? And then how do you help folks? Next. So how we ask, like I mentioned before, it makes a world of a difference. And it's no longer just cigarette smoking. There's this ton of products now, and do people identify as smokers? That just takes one look to say maybe not. So here's something our California Quits team and the California Smokers Helpline tried to refine. What is an efficient question to ask in the clinic, and how do we start training medical assistants and providers to ask this? So have you used tobacco products in the past month, including vapes? And sometimes you have to go into what are vapes, because we've heard people say e-cigarettes are what my grandma uses. You know, I use a wax pen, or, you know, they don't identify with certain products. And if they are vaping, because we've had this epidemic of EVALI, we should be asking now, do you use nicotine, marijuana, or both? And then if you have the time to ask them, you know, what are their sources, and are they licensed? That may be also important to as you try to stratify their risk. Next slide. So just a very brief thing about California vaping and marijuana use, and that there's a lot of co-use now of these products. So this is from the California Tobacco Control Program, and you can see overall it's still, those blue bars show cigarettes are still what people are mostly using in the general population of adults. But when you look at the young adult group, you can see vaping is on the rise. And then just some information on the right just to show that marijuana use is rising, including in young adults, and people are co-using tobacco. I've asked my patients before who've used marijuana, I've asked them, you know, why don't you use edibles? And one patient said, you know, I can't control the high. By the time I've ingested it, and there's so much variation, at least I can put down something, you know, that I'm smoking or vaping. You know, that's why I choose to use it this way, despite maybe the potential for lung issues. Next slide. So what can you advise? This is one line that I say to folks quickly in the clinic: the best thing for your health is to be smoke and tobacco free. There's no safe tobacco product. There's also no risk-free level of smoke exposure. Next. And the CDC has this very nice graphic to show that in vapes and other products, they call it aerosol. They don't call it vapor, because a lot of people think it's water vapor. But the aerosol actually has a lot of chemicals and particles and flavors, where we're just starting to learn about some of these flavors and the health effects, especially in the cardiovascular system, like diacetyl, the aldehydes. Anyway, we're learning much more about some of these health effects, that it's not just a harmless issue. Next. So how can you assist a smoker to quit or a tobacco user? There are 7 FDA-approved medications that double the chances of quitting, and these have been studied very well, 5 of which are nicotine replacement therapy, patch, lozenge, and gum. Probably most folks know about them because they're over the counter. UCSF Pharmacy is very good about championing combination use, so long and short acting, which makes sense for, we do the same thing for pain, so people can titrate. There's also the inhaler, which is not into the lungs. I think in the UK they call it an inhalant, but you just rapidly puff into it, and the nasal spray as well. So all of this is buccal absorption, or, you know, back of your throat. It's not into your lungs. And then of course there are 2 pills, varenicline and bupropion. And just to note that the U.S. Preventive Services Task Force and the 2020 Surgeon General's report still says there's inadequate evidence to recommend electronic nicotine devices for tobacco cessation. Next. So what else can you do? Refer to the California Smokers Helpline. The California Smokers Helpline, I always joke, it's one of the best kept secrets in the state. Free telephone counseling, and now they, it's not just cigarette smoking that they help. They also, with all the EVALI outbreak last fall, they were able to stand up a whole vaping service line. And it's not just replacing one word with the other. Their counselors are actually educated about the terminology and how people use it. And so what does a helpline do? You know, now more than ever, the telephone is probably very useful, and they will do one-to-one counseling up to 4 follow-up sessions, and they also have more tech options, so you can text them, and they will convert to chat if people reply, and there's an Alexa skills coach and a No Buts app. If somebody really wants to try to access in-person counseling, they have resources of what's available in every county. Next. So what happens when you call? This is just a chart.
10 minutes.
This is just a chart to show what happens when someone calls and it doesn't have to be a smoker or a tobacco user. It can be someone calling for help for that person. And they do actually get a lot of these friends and families calling for help. So they'll send them free educational material. They'll, if someone requests counseling, they'll either do it on the spot or they'll schedule for another time that's more convenient. And as I said, they will do follow-up calls as well, and they service Spanish and Chinese, Vietnamese, and Korean. So folks have asked, are they in service because of COVID? They have been able to stand up their operations remotely, and so they are still very much in service. Next. So our California Quits team, we are putting together some materials, so scripting for providers and staff. And also, I wish I had this to share with you today, but we are compiling how health systems are integrating smoking and vaping into COVID care. So as many of you may know, UCSF has a question for about vaping and smoking nicotine or marijuana in their COVID screening algorithm. So we've done that also at UC Davis. We've also incorporated smoking into the risk score for COVID that we have. And also I've helped develop some very simple patient education information for people at discharge. Next. So to wrap up, just to touch on a little bit of population health and some takeaways for action. I'll talk a little bit about what we've been doing at UC Davis. So as I mentioned, we have at the Comprehensive Cancer Center Stop Tobacco program now, and we align very much with health management education, of which I've seen the team on today. So shout out to all of them. And we partner also with Carrie Shulkin, our tobacco treatment specialist on this. And the cancer patients who smoke, we know this is the most immunocompromised population, and there's growing evidence. Well, we do know that once you treat your tobacco, you also have better cancer outcomes in terms of improved healing and survival rates, and also treatment outcomes. Next. So here's a tip about what we're doing, and we are bulk messaging out to the cancer patients who smoke. Looking at our registry of smokers, and just including a brief version of what that article that I helped post that I showed you in the beginning. And then, of course, people can respond back to us, but what we are doing is we're not waiting for them to come to clinic. Carrie is actually helping to call out to folks who haven't had any documented assistance, or follow up on people who have requested assistance from this outreach. And so we're very lucky that the Cancer Center has also been very good about trying to get more folks online. Next. And then at LA County Department of Health Services, we've already had this successful pilot where we've implemented an electronic referral with the helpline. But now we're trying to expand upon what can we do in terms of population health, have the helpline call out to their unassisted smokers to help them meet quality metrics. And we're also looking to see how can we improve the contact rates of people who have already consented to being referred. How do we streamline provider workflow? But also, how do we integrate medications? There have been several special offers that we've had with the helpline. And so how do we do this long-term? We're working with the health plans, the Medi-Cal health plans, to try to figure out how do we do better care coordination. Next. So in the meantime, when COVID happened, though, we decided to pivot a little bit and not just make this integration of medication pilot for LA County, but we made this available for all Californians at home. So if there's anything that you want to take away from today's talk is know that the helpline has a special offer right now for a 2-week starter kit of nicotine patches to be mailed directly to callers that are eligible. And there are the other offers. So in the Bay Area, Alameda and San Francisco County residents are able to have county funded patches, and First 5 and the CDC also funds some separate special offers. But this was something we felt very strongly was important to try to help all Californians as everyone's sheltering at home. Next. In case you're wondering, does that work? Does that help? I just want to say a couple words about the Medi-Cal Incentives to Quit Smoking project, which I helped work on with Neil Kahatsu, who was of course, the medical director of California Department of Healthcare Services. He was the PI for this. I helped with the statewide outreach. And we were promoting a $20 gift card incentive for people to call and complete a counseling call. And then we were also offering nicotine patches, and it may not sound like much to have medication as an incentive, but we actually were able to increase the number of Medi-Cal smokers who called the helpline, and Medi-Cal represents about 40% of California smokers. So next slide. And just wanted to show you out of the monthly calls that we had over this whole project period, we had this push out to all households where we mailed out to all the households in Medi-Cal, so about 6 million people, and we did this 2 or 3 waves. And all we did was have the information about the free nicotine patches on it, and you can see we had a huge surge in calls. It actually shut down the helpline for a month or 2. They couldn't get back to them right away. But just want you to know that this is something that we can all do as a population for population health together. Next. So if you want to learn more about this, here's some information, and you can look at our published supplement in American Journal of Preventive Medicine, and there's some information about the cost benefit as well. Next slide. So to wrap up, we do know in California, we're very lucky to have low smoking rates compared to many other states, but we still have almost 3 million smokers still, and we do know a lot of people are vaping as well. So that graph to the right just shows we do have a lot of regional disparities as well, especially in the northern rural areas. So that's why we also feel very strongly about trying to make this free nicotine patch offer available at this time, even though 2 weeks, it doesn't, it's not a full course, but at least it'll get people over the worst 1 to 2 weeks of nicotine withdrawal symptoms. Next. And then finally, just a shout out to our California Quits project, because as we, just like this wonderful forum for RightCare initiative, we are also trying to share best practices and how our health systems and Medi-Cal managed care plans and the public health partners funded to do tobacco control, how do we all work together more collaboratively at a local level and then share across systems as well. So we are the Tobacco Treatment Learning Collaborative for the safety net hospitals that are participating in the Medicaid 1115 waiver for Department of Healthcare Services. Next. So just some takeaway points. Smoking and vaping increases the health risks for COVID. Take a look at that information on the website and see if you can push it out to patients. And also to colleagues as well, and your local public health departments. How do we adapt better to treating tobacco cessation for patients and providers, especially with people being asked to stay at home more? Hopefully, you'll think about not just the tobacco users, but also the people living with them as well. And then also think about how to do population health integration with the California Smokers Helpline. We're no longer just trying to wait for people to come into the clinic and be helped. We can do this in a much more proactive way and work together with the health plans and registry lists of who are our identified patients who use tobacco. Well, thanks very much. Feel free to connect with us and contact me.
Thanks so much, Dr. Tong. Can you guys hear me?
Yes, we can.
I think
Yeah.
there's one question real quick from Dr. Yu. Are there different tobacco cessation approaches that are specific to patients who vape? Can we make smoking cessation advice the same regardless of modality? What do you think about that?
Right. So I would tell a patient, again, smoking tobacco free and is the best thing for your health, whether you're a user of cigarettes, vapes, or you're someone being exposed to someone else's smoke or aerosol. I think the problem that we're trying to figure out right now is how to dose nicotine. And I know the UCSF pharmacy folks are talking to the helpline. They're trying to figure out a protocol, but there's no standardization in all these vaping products. They're not even, their contents are not yet regulated by the FDA, although they're supposed to start later this year. So, and of course, how people use the products, we may need to start measuring cotinine to actually get a sense of how dependent people are. There's a lot to be learned. One final thing is for the pediatric population, I often get this question, there's if you look at the literature, it says there's no evidence that that nicotine helps teens quit. But we need to. That doesn't mean it's a contraindication. If you are a pediatrician and you think that person needs it, you can help prescribe to that teenager.
Thanks so much. Okay, so hi, I'm Nirali Vora. I'm one of the stroke neurologists here at Stanford and a co-chair for the RightCare initiative. Sorry, I was late. I have clinic patients on Tuesday, but I really enjoyed hearing everyone's presentations. Next slide. We're going to keep moving right along. Next, we have Dr. Carvel Teft. Dr. Teft actually has experience in internal medicine, both hospitalist and primary care side. He is now a physician executive, has had a lot of work in different healthcare systems, including Sutter, as well as the Hill Physician Medical Group, and is currently serving as VP of Medical Management for the Santa Clara County IPA, I believe. Did I get that right? And Dr. Teft is going to be joining us today to talk about the IPA's response to COVID-19. Dr. Teft?
Yeah, great. Can you hear me okay?
Yep. Go for it.
Wonderful. Okay, I haven't had the luxury of an internet connection since mid-afternoon, but the presentations have been great, just listening on the phone, and really compelling. So thanks for inviting me, and just want to quickly say that this presentation overlaps with my board meeting, which starts at 6 o'clock. So right after I finish up, I'll probably have to jump off. And Brian, I'm gonna have to rely on you to shepherd me through this. We can go to the, what I'll call the first slide, which is the COVID impacted community.
Yep.
Great. So this is probably stating the obvious, but COVID is affecting our entire universe of healthcare. We've seen it, and I certainly have seen it in the SCIPA network with our hospitals that prepared for a huge surge, which to date has not happened, thankfully. And I've been in touch with a lot of our provider practices, and they've been devastated by this pandemic. Anywhere, their business is down anywhere from 50 to even 90%. They've had to lay off staff. So there's a big impact there. You all know that in our ambulatory surgery centers, elective surgeries have been canceled. So we're seeing some big changes. And of course, labs have been responding as appropriately, but in the beginning, it was kind of up in the air as to who was doing COVID-19 testing and who was responsible. And could a patient just show up in a Quest lab or LabCorp and get the test done? So our entire universe has been affected, and I'd like to think that universe surrounds the critical relationship between the patients and our providers, and I think that's where SCIPA has a level of expertise. Next slide, please. So if you don't know about the Santa Clara County IPA, I actually, my employment is with PPMSI, which is the management service organization, the business entity which supports the Santa Clara County IPA. But we have a membership of about 26,000 HMO members right now and 65,000 attributed PPO members. And what's I think unusual about our IPA is that we're seeing a reversal in the declining HMO membership that almost everyone has seen except Kaiser. And that started in 2019. And so I'm kind of very happy with that trend. And also our provider numbers are up higher than they have been in 5 years. You can see that we have 866 total providers in our network, and some of them are exclusive PCPs. We have multiple hospital contracts in the county. Of course, we serve Santa Clara County, and we have multiple specialties covered as well. That's just a broad overview of our network. Next slide. So you'll see this is the way we started responding to this crisis. I don't think, honestly, that SCIPA is unique in any way. I mean, we've all had to adapt so quickly to something that's been unprecedented in our lifetimes. And I'm just amazed at the stories I've heard today and what I've heard from my colleagues. But we sort of adopted the, flight strategy. When you hear your flight attendant say, put your own mask on first before you help your child, that's what we knew we had to do to support our providers. And so 4 days before the shelter in place, we sort of saw the writing on the wall, and we wanted to make sure that all of our employees were had the capability to work remotely. Some of our employees had never worked remotely and only had desktops and did not have laptop computers. So there were 83 of us, and we moved folks out on the 13th of Friday. And then in phase 2 and 3, we were able to get the rest of the team out very quickly after the weekend on Monday. And hats off to the IT team for doing this and providing all the equipment that was needed. And to date, I have to say this has been a very smooth transition. Next slide, please. So I'm just going to go through some of the departments and how they've all contributed at SCIPA. Our network management team has been tremendously busy. They've made more than 1,000 provider calls. And at first, we were just checking to see if offices were open or, were the hours reduced? Did they have telehealth capabilities? Were they interested in providing telehealth? And of course, we wanted to find out about their needs for protective equipment and whether they were testing for the virus. We communicated to our members on our website, and we upped our customer service staff to answer any questions. We probably didn't do anything outstandingly unique in that area. We just provided our members with all the information that you've seen as far as prevention and links to sites that were helpful. We did reach out to our practices to make sure that they felt supported. We encouraged telemedicine use. We pay fee for service for telemedicine use, whether our providers are capitated or not. And we provided them with all the information they needed to code correctly. We also, of course, supported them with information about the CARES financial relief and the CMS and DMHC waivers, and inquired as to whether they planned on pursuing or had received checks. And probably the most challenging effort in all of this was getting masks. And maybe some of you have experienced that same thing. But we were out there calling our health plan partners and sort of begging for anything, friends, family, and we finally had a breakthrough a few weeks ago and got significant numbers of masks and other protective equipment and distributed them to our providers. And the gratitude that I've heard from those providers has been just tremendous. And I can't say enough about their struggles and how they're dealing with this and our attempts to support them. Next slide. This is a graph that shows how we've gone from 0 to 60 quite quickly. It's a little confusing on the horizontal axis. Those aren't the actual dates, those are days, but these days represent March 10th through April 20th, where we went from 0 telehealth claims to over 250 telehealth claims. And to date, we've had more than 3,000 telehealth claims, which in some health systems is probably no big deal at all. But for us, this is a tremendous change. And so we can see that our doctors are adapting to this, trying to do the best they can to take care of their patients, and doing it in a way that they've never really done it before. I'd like to add that I think there is a silver lining in all of this, in that for those independent doctors that have, for one reason or another, been a bit reluctant to dip their toe into telehealth, dip their toes, this is a nice little jump start. And I think the potential is enormous. I do think there's a little bit of a benefit to this crisis that we're seeing. Next slide. The medical management team is a team that I manage, case management nurses and nurses, and just want to describe some of the efforts that they've undertaken. We have a transition of care team. This is a team of nurses that checks in on patients within 48 hours after discharge to make sure that critical time between discharge and going home is, things were safe, that medications were received, that DME was received. So we expanded our outreach. We used to reach out to just those seniors that scored in the high risk category, but knowing that for the most part, all seniors, especially with this disease, are at higher risk, we started outreaching to every Medicare Advantage patient. And we continue to reach out to our high-risk commercial patients. And on top of that, before they even got sick, we revitalized our risk report, which is not a very, frankly, sophisticated risk report. It's a RAF report, the risk adjustment that CMS uses. But it is a way to risk adjust our seniors. If I had my druthers, I would like to adjust by disease process as well, by COPD, by heart disease, because we know those folks have a higher risk. But this is a start. And so one by one, our nursing team is reaching out to high-risk seniors before any utilization to make sure that they're doing okay. In the authorization department, things are moving along just as usual. The auth department has worked remotely for quite some time now, and so I don't think we really missed a step. But one thing that I am seeing is normally when procedures or images are requested that are out of our network, that's something I would normally deny. We do have a closed network. But given this crisis, if this was going to stand in the way of really good medical care that would be hard to accomplish by delay, I was going ahead and accepting and approving the authorization. So as an example, we had a patient leave the hospital who had cellulitis, and the cellulitis appeared to be getting worse. saw the PCP afterwards who wanted to get, it sounds like a small deal, but for us, actually, it's not. Wanted to get an ultrasound and sent it to a non-network provider, but I wasn't going to stand in the way of ruling out a DVT or ruling out a soft tissue abscess or something like that. On the inpatient side, we have inpatient nurses that are following our patients closely, and they worked hand in hand with the hospital case managers, opening up hospital beds and ICU beds to prepare for this surge, which, as I said before, hasn't happened. And as you all have read and experienced, there are some outbreaks at our SNFs, and they're probably not the safest places to be if they can be avoided, if at all possible. And so we're working our hardest to get folks home with home health if necessary. And on my side and our CMO, Dr. Kraft, we've been reaching out to our docs one by one, asking them, how are you doing? What can we do to support you? Is there anything else you can think of? And, you know, as you can imagine, some of them, as I said, are a little devastated. Some of them are doing tremendously and have really adapted quickly to telehealth. Some have remained open and are doing COVID tests regularly. So it's all over the board, but we wanted to make sure that their voices were heard. The next slide is a simple graph which just shows the outcomes of our efforts to do more of that transition of care outreach. In January and February, our numbers were closer to 40 outreaches, and in March we were up to 60. And I looked at April's numbers recently, and we're going to surpass 60 in April, which shows that we're actually accomplishing what we set out to do. And I'm going to finish with just some stories, you know, that really have touched me. And I received 2 more stories today, and I receive them every day. But we had a patient that was discharged with a DVT who was prescribed Xarelto, and this medication wasn't discovered by the health plan. And our nurse took, you know, half her day to find a pharmacy which was able to provide the medication for free rather than a $500 out-of-pocket expense. There was another patient who was discharged, and his PCP had very limited hours, not able to see any new patients. This was a new patient to that PCP. Patient was assigned to that PCP. And so we quickly found another physician to accept the patient. And a post-op patient after hip surgery did not have home health or PT and OT at home for whatever reason. And we were able to get that done overnight and sent in the home health nurse the next day. Finally, I don't know what I really liked about this last statement here on the bottom of the slide, except for I think the care goes both ways. Sometimes we as providers, you know, we give and give and give, and sometimes it's nice to receive too. And one of my nurses sent me this little blurb. You could read it. What's heartwarming is receiving calls from 3 different patients I case managed years ago just to check in on me to make sure I'm doing okay. And that was my quick summary of what we're doing at the Santa Clara County IPA, and happy to answer any questions.
Thank you so much, Dr. Teft. And I know you have to run to your board meeting. And I don't see any questions at this time. So maybe while we're waiting for any to show up, I'll start introducing the next speaker. But thank you for sharing that experience of what it's like on the management end and how multiple system changes had to come together quickly to adapt and make change to cover us in this time.
Yeah, my pleasure. Thanks.
So our next speaker has spoken with us before, Tatiana Consavelli, who's born an app developer, but has really managed to do so much, both in and first outside of healthcare and now in healthcare. She's spoken to our group before about My Cardiac Coach and her platform for digital health for coaching and management. And today she's going to continue to talk about sort of that platform in the context of change. So Tatiana, are you? Yes.
Yes.
You can share with us about the management system.
Thank you. I'm glad to be back, and thank you for whoever survived beautiful talks, but I know everyone is pretty much tired and ready to get their drink. That's what we're doing when we're in a lockdown. Next slide, please. I launched Open Health Network at the White House Demo Day in 2015, and the whole notion was to create a framework that will enable rapid development, rapid meaning days, weeks of highly adaptive, AI-driven, personalized digital health offerings, mobile voice apps, chatbots, and everything in between. Next slide. So one of the examples that relevant to this group is an app built by American Heart Association on our platform, My Cardiac Coach. Next slide, please. And it gears towards patients who had heart attack. The main point was to give them enough tools within this one offering that they can use to manage all the aspects of their lives so they wouldn't get repeated heart attacks. It's available in English and Spanish. It's a free app, runs on any device in any language. You can see a dashboard. They know how to learn CPR. They can track their health data. There are a lot of real good interactive content with assessments. They can find closest rehab, and they can do pretty much everything they need to do in their life. Next slide, please. There are some of the modules that have been deployed within the My Cardiac Coach. As you can see, they can set up lifestyle goals and measure their progress based on their goals. Next slide. Health data, they can pull data from Apple Health, Google Health. If desired, they can integrate with any type of wearable devices. Next slide. They love these lessons and then assessments that are available, and content gets updated frequently. Next slide. And medication tracking, of course, with reminders as well. Next slide. Now, what we've realized working with major healthcare organizations for a number of years, from UCSF, UCLA, Cleveland Clinic, Mount Sinai, that there is a need for continuous care. No one knows what happens to patients in between appointments. Next slide, please. So we came up with this integrated framework that can be adapted to any type of condition, and it has physician-facing dashboard. Within the physician-facing dashboard, you can create a care team that can consist of practitioners from a variety of different disciplines. They can have different roles. There are a variety of different workflows, permissions, and based on their roles, of course, they can execute and do different things. Next slide. So this is an example of the physician dashboard where they can see their patients, and there is an AI algorithm that actually triages patients, so you can see which ones you should be paying attention to. In this case, there is a case study that I can send to you on Mount Sinai, deploying it for Crohn's disease, IBS, IBD patients. There is a set of assessments, they name it playbooks, and all those assessments can be done by a variety of different specialists. They can assign within their dashboard certain assessments that immediately get populated within an app. And there is a daily schedule where patients can see exactly what they need to be doing, how they should be doing. As soon as they do things, dashboard gets updated. Next slide. The beautiful things on the back end, and all of this is completely configurable, customizable, that you can, as a physician or group of physicians, create a sequence of things that you want patients to do. That sequence can include activities, target heart rate, medications, assessments, surveys, anything in between. And you can, with one click, adapt those and assign on a weekly basis, every day, whatever it's needed. As soon as you do that, and that is comprehensive integrated care kind of thing, it immediately gets updated on a patient site. Next slide, please. So patients can get the daily kind of calendar, and they can see everything from health tracking they need to do to what type of exercises. It actually includes videos on how to do it the right way, and literally every single thing that you want them to do, from medications to activities to assessments, take your temperature, everything gets updated on daily schedule with reminders. As soon as patients do stuff, it immediately gets updated on the dashboard. Algorithm cranks the numbers and triages and highlights the patients that require attention. Next slide. The cool thing is that for one of the healthcare organizations, very well known, they wanted also to integrate with the app on a device. In this case, it's Fitbit. So we wrote an integrated Fitbit app that patients wear, and as soon as they reach target heart rate based on the prescribed activity, again, it all triggers the workflow all the way to the physician dashboard. Next slide. So when COVID started, we realized that there is not enough testing available, and there is some kind of need for people to track their symptoms, and there was a hypothesis that we can use combination of symptoms to figure out if people potentially need to do testing or have a COVID. So we used our framework, and within literally from start to finish, within 2 days, we released this free app that's available in 5 languages. So it's in English, in Spanish, in Chinese, Russian, and French. Any language can be added within a day, as long as we have translation. It runs on any device. And people can track all major symptoms that physicians told that they need. But more than that, if you can see the button on the top right corner, they can share that data with their physician. So it's a free app, and we released it in the wild, and thousands of people start using it. So we immediately published a heat map based on correlation of symptoms, where we potentially see upcoming COVID hotspot, because we could correlate. Testing is not available, so that could indicate certain things. So that's published on our website. Then we've been approached by a large independent physician organization, and they told us that, you know what, like we needed, people do telehealth, and then our nurses have to call them based on protocol every other day and so on, but we don't have access to any data in between those telehealth visits. So we enabled our physician-facing dashboard that's integrated with this symptoms tracker. And now physicians can see on the dashboard all the symptoms, and they send us the triage logic that we applied. So you can see high priority patients first. And now we're adding the piece from the dashboard has been deployed everywhere, where you can immediately start assigning integrated set of actions for those patients that immediately will be pushed back to their device, and they can start doing set of corrective actions or prescribed actions. So all of that has been deployed. It's free. The patient-facing site, you can play with it. And it's highly customizable. So now the whole framework companies want to use it to to enable people to do self-assessments before they come to work, right? And this, it immediately gets available in the dashboard. So, and we have now evidence-based 14 symptoms with ranking, and we develop an algorithm that accurately assesses different combination across those 14 symptoms, and can tell people if they're green, yellow, or red in terms of the probability of having COVID, and based on that, recommend them to stay home, or they should be green to come to work. So that's where we are today. And again, it's completely configurable, customizable platform, completely seamlessly integrated. Here's some links. So if you want to play with the app, it's covid.openhealth.cc. Everything is white labeled, so you can white label, you can change to whatever you want it to look. Heat map is published on openhealth.cc. And there is a link to my cardiac coach if you want to download and play with it. And there is also a white paper that Mount Sinai has published on chronic disease management in COVID times. So that's available to download, or send me an email, send it to you. And I just spoke at UN and with World Health Organization, and they're trying to roll it out worldwide, and I'll be flying to Geneva, hopefully, if everything will clear up, and speak at the UN in August on this. Thank you.
Thank you, Tatiana, and congratulations. That's really exciting.
Thank you. This is just sample list of customers. Thank you. Yeah, I think that's the last slide.
Any questions for Tatiana and her app, especially the COVID specific focus one? Looks like that's open for everyone, so we can all go play with it ourselves.
Yeah, and it can be easily adapted to cardiovascular, so we can add specific for any condition, and then logic related to additional symptom trackers.
Got it. Okay. Well, I think we can keep moving forward then. Evelyn, are you with us? Otherwise, I can do. So Evelyn is my co-chair here for the Silicon Valley Best Practices University of Washington. Okay, there she is. She needs no introduction. She's the cardiologist as well as an endocrinologist by training, and is faculty at UCSF, doing both clinical and research-based care in lipoproteins. But she's going to speak a little bit on COVID response and the way forward.
Yes, thank you, Nirali. I think we have all attended many webinars and daily briefings on COVID. What I want to present as a slide, Brian, do you have the slide? This is taken from a paper from Deepak Bhatt, who summarized in this figure how, in his view, the crisis of COVID-19 will hopefully serve as an unintended force to modernize and revolutionize medical care more broadly. It really spoke to me and gave me hope, and I thought it was a beautiful piece. So I wanted to share it with you, especially how it sort of outlines the different domains that are probably going to move this forward. Telemedicine is one of the giant ones, as we have seen during this program today. And one of the things that it has allowed for me personally, as I shelter in home and in the medical center here today, I'm in the Echo Reading Room at UCSF, and I have been able to talk to some of my patients, read echoes. We are reading echoes remotely. So it has definitely increased our outreach to patients and expand our home monitoring capabilities. One of the difficulties for me has been trying to figure out what to do about physical exam and how to reach patients monitoring. And we have seen beautiful examples today of how these technologies have evolved and can provide these out-of-the-box solutions. The other one is to ensure reimbursement. And one of the surprises at the beginning of this crisis for me was the Centers of Medicare and Medicaid Services worked very diligently at the beginning of the epidemic to remove the administrative barriers during this pandemic. And for telehealth, CMS waived penalties for HIPAA violations. We were very restricted before. We could only use certain telehealth methods. At UCSF, we started using Zoom, but had very low penetration in the population. By now, it has expanded substantially, and most providers are able now to provide care. Even my 80-year-old mentor is providing care for his patients effectively via telehealth and able to contact them. Also, the Center for Medicare and Medicaid offered reimbursement for telehealth services, further incentivizing healthcare providers to offer these services to minimize the need for patients to visit healthcare facilities. And it has made us use resources very judiciously, and we have all seen a decrease in the number of testing ordered for patients and global collaborations, of course. And I'll leave it at that, and we can continue the conversation after.
Thanks, Evelyn. And actually, to help continue the conversation, just in the chat box, I wrote a message for anyone to respond. What positive change from this pandemic will you take forward with you? And so we heard from Dr. Taft about, continuing with telemedicine, but I think that everyone may be impacted in some way. So feel free to respond in the chat box, and you can go to the next slide. You don't have to introduce me. So I, in the same way that UCSF and Evelyn kind of shared about how there were rapid changes done, we have made similar changes at Stanford in terms of telehealth, judicious use of resources, also a lot of, high value communication at multiple levels and having those touch points, which has been important from both burnout, anxiety, but also just general communication. So I won't get into that. I was actually going to switch to a couple sort of stroke and cardiac related things. Some of you may have seen this letter that was published today in the New England Journal of Medicine. It's out of Mount Sinai in New York with 5 young patients, ages 30s to 40s, 2 of whom did not have any vascular risk factors, who presented with large vessel stroke. So they presented with dense hemiplegia and aphasia, for example, came in as stroke codes, and either had very mild or asymptomatic symptoms from a COVID perspective, but were ultimately COVID positive. And I just bring this up because, yes, there has been news sort of anecdotally about reduced hospitalizations and procedures for MI and stroke. And there is this question among those that already have risk factors, where are they? But there's a second issue, which is among these patients that have COVID, there does these young patients, I think, illustrate that there's something unique about the virus, about coronaviruses in general, that may be driving stroke risk, as well as probably similarly the MI risk. And the postulated theories, and we have a case we're trying to write up as well from the county, but mostly all of the workup is negative except for some of the inflammatory markers and a perception that a lot of these patients, although not described in this case, but in our case, for example, also have a lot of hypercoagulability, and that there is some sort of inflammatory driven hypercoagulability that may in fact be leading to a lot of the strokes, and some even postulate some of the response that we're seeing for the acute respiratory response syndrome. And so I think that if you guys haven't, you can go to the next slide, take a look at it's small here, but these are the 5 patients in the description of kind of how they presented. And just a reminder that regular risk factors or not, we do need to be mindful as we take care of our patients and balance shelter in place with managing acute presentation. So that was one message I wanted to share, particularly as a stroke neurologist. And this is available from today's New England Journal. So we can go to the next slide. And then in the past, I think last month we talked about, and there's been great discussion in this group about the risk or benefit of ACE inhibitors and ARBs in this disease. And that last time we concluded that we just don't know, that more research is needed, and that the current societies nationally are recommending that patients continue with ACE inhibitors or ARBs regardless of their COVID-19 diagnosis. And in a past talk, I think it was our prior speaker said, well, sure, if they're in shock, you know, like any antihypertensive, you would hold them, but that we don't really have good data to suggest that this is definitely increasing risk of transmission or infection. And this article is from Wuhan, China. It's sort of just a observance of a series of patients at a single institution. And so you have to sort of take that with a grain of salt. But I do think it's interesting, next slide, that among the patients with hypertension, those that were on ARBs compared to those that weren't had no difference in the terms of the severity of their COVID-19 illness or their comorbidities, whether it was CAD, coronary artery disease, stroke, or it's not shown here. Oh, I think it is shown here, the non-survivors, or death. And so the first glimpse to sort of support what our societies are recommending about just continue on with the ACE inhibitors and ARBs. But I do know that there will be ongoing research and ongoing reviews on this topic. And just, you know, when you think about the pathophysiology, it's confusing. Some of you may have read this, and this is written in this article. You can go back and reference it, but that I'm just going to read it actually, because I thought it was interesting. Levels of ACE2 are a double-edged sword. On one hand, the increased expression of ACE2 may facilitate infection with COVID-19 and increase the risk of developing severe and fatal COVID-19. On the other hand, decreased expression of ACE2 can induce pulmonary edema and reduce lung function, which can be reversed by losartan or other recombinant ACE. Therefore, increase of ACE2 could be protective against lung injury. And so it's sort of unclear exactly how these ACE inhibitors are interacting with the disease. But I wanted to leave that with you so you can think about it, especially as you interface with our patients and work to slash stroke and heart disease in our region, even in the pandemic. Okay, let us take questions. That's all I had. And yeah, feel free to read the chat box about what people are saying about what they're going to take time for, both in their medical work as well as, I think, importantly, with family and appreciating everything that's going on. Thanks, everyone. Any questions? Other questions? There was one question posed earlier on about ABO blood types and its impact in SARS-CoV-2, given evidence from the 2002-3 SARS epidemic that ABO blood type may have some impact on disease outcome. I know that there were reports about this earlier on. I actually haven't seen any follow-up information about this, and if any of the panelists have more information, feel free to chime in. I don't have an answer for that question. Okay, I'm just going to read a couple of these before we sign off. It's time for healthcare to embrace high potential digital health technologies and make remote care truly effective. It's time to enjoy the simple things: game night with family, yoga on YouTube, and using technology to connect with family, friends, and health. Let's investigate and champion effective innovations in healthcare delivery. We have been doing the same methodologies for 50 years without achieving the outcomes for the most of our patients. Now we have seen innovation and may offer more opportunities for success. Thanks, everybody. Oh, one more. Let's see. Yeah, very good. Hattie, do you want to add anything else before we wrap up? Everyone made it to 6:50.
I have to say, I have long been accused of overpacking an agenda, and I think I did that again, but it's hard to pick among all the great relevant presentations as we are trying to just in time tackle this really tough situation. So I just appreciate everybody in this community sticking together, coming together, working together. Even when we're not doing our meetings, the dialogue that's going on, the information exchange is really, I'd have to say, very heartwarming that people have gotten to know each other over these 12 years in this collaborative, some for shorter times and some for longer. And I'm impressed that there are still 41 people on the phone or on the session at this hour. So I just appreciate you all. And I know that you're putting yourselves out there. You're really putting your lives on the line for the patients. And you are the unsung heroes. And I want to just thank you for all that you do. And I also want to invite you all, if you want, to participate in our next 3 action-packed agendas, which will be on May 11th, May 21st, and May 26th, because those are our normal in-person meeting times. And we have great presenters coming up. So we will be sending you information about that. Our next session, we will have Marilyn Stebbins, who told her patient story. On May 11th, she'll be part of our program talking about her phenomenal pharmacist on the care team program at UCSF. She's been a national leader on telepharmacy and optimizing medication management to keep people out of the hospital, which is an even higher priority now than ever, because we have the potential of circling back to our work that was the project when we first began, which was on hospital-acquired infections. So one of the things we have to worry about is when patients come in for non-COVID-19 things, we're seeing some articles, some papers about the high level of getting infected while getting regular care. We haven't seen those articles in the United States yet, but I can only imagine, given Marilyn's story, that is one of the things that we should be very concerned about. We're also going to hear on May 11th from Earl So, who is a telemedicine leader for the Veterans Administration. He presented this program last summer to us in our Los Angeles forum. And I will not go on reading about all the wonderful things that we have coming up. Everyone has their families to turn to, and we need to think about, should we be changing the time of this particular forum? So we can do that offline. And I just say, I'm so grateful to all of you. Thank you for your leadership, Evelyn and Nirali and Joe Sky. You haven't said a word. How about if you unmute yourself and just say hello to everyone? Now you're in the dark for some reason. Okay, there you go. But you got to unmute yourself.
Thanks. And it was wonderful presentations today. Really appreciated everybody's presentations, and I learned a lot. Thank you so much.
With that, perhaps we should just thank all of our wonderful speakers. Eliza Tong from UC Davis. That was a phenomenal presentation about something that's even more relevant now. And what's not to love about free resources for helping the patients through this time? And the one thing you didn't mention in your presentation was a caution about marijuana smoking. That's not good for your lungs either. So I hope you'll build that in. And I know that you had so much to cover, but perhaps you can build that into a future presentation. And Tatiana, I see you're still with us. Bless you for your just-in-time work to use artificial intelligence and large data to help look in the records also for what we already have. For instance, a positive heart CT scan that would help us to triage who are the important patients that need outreach. So with that, I'll just say, bless you all, thank you all, and we will meet again by video on May 11th, if not sooner. So thanks again, and good night.